is the last of the case series and the last of the lectures. And مثل ما تعودنا, we start by washing our eyes and refreshing our memory about what a normal glomerulus looks like. With its very thin glomerular basement membranes, normal cellularity, mesangium not expanded, normal mesangial cellularity with less than 3 or 4 mesangial cells per loop, and basically ما عندنا hyalinosis في الهايلر blood vessels. Okay, so and we start and then هاي الصورة اللي انتم الحين متعودين عليها اللي هي basically a segment of a glomerular tuft. And we're looking at the glomerular basement membrane over here. We are lamina densa at the normal thickness, اللي هو almost the height of a regular podocyte. Podocytes are slightly activated, but they are maintaining their distance from one another. There is no effacement. Each one of them individual. The endothelial cells that are flattened on the inside of the glomerular basement membrane, they're not swollen. And then we have a mesangial matrix, and then we have the mesangial cell, هذه النيوكليوس الغامقة. So this is just us reminding ourselves of all of that. So today I have 4 very interesting cases حقكم. And we start with the first case. The first case is of a 75-year-old woman. She presents with acute renal failure. كانت البيسلاين مالها يعني around say 1.2 1.3. فجأة she presented with acute renal failure والserum creatinine مالها is 8 milligram per deciliter. وشافوا إن عندها pulmonary hemorrhage وعندها hyperkalemia. ليش عندها hyperkalemia؟ سبت acute renal failure. So light microscopy مالتنا, what do we see here في tubules? Do you wanna discuss it في chat box? Okay. So what type of casts do we see? We're seeing casts, بس هذه الكاست شنو؟ Yes, exactly. They're red blood cell casts. بالضبط. So we have red blood cell casts, and whenever we have red blood cell casts, we always think there is possibly a crescent somewhere. فيعني إذا انتونا شفتون إن انتونا عندكم red blood cell cast في البايبسي مالتكم بس ما محصلين the crescent, يعني ممكن MA, ممكن إنه يكون crescent. Always basically do levels in this instance, and do levels يعني سووا واحد HNE واحد PAS واحد ترايكروم إلين ما تحصلون الليجنال يعني سبب إن إحنا وايد we have red blood cell casts, and يعني we wouldn't have red blood cell casts without a reason. Say for instance we didn't find a lesion, then we have to basically then suggest in rebiopsy there is a red blood cell cast, especially إذا كان عندهم active sediment in their urine analysis. So in this instance, we actually can see the reason of the red blood cell cast. احنا هني عندنا 2 glomeruli and they don't look healthy. So I'm going to show you how these look على high power. So this is PAS. there is rupture حق Bowman's capsule. And there is kind of like a proliferation of parietal شو اسمه epithelial cells, endovisceral epithelial cells, وعندنا شوية inflammatory cells بعد in the mix. So basically we are looking at a crescent over here. So احنا عندنا crescentic glomerulonephritis. Again, this is a trichrome, and we can see in kind of like a break over here في the glomerular basement membrane, kind of like shriveled and يعني ischemic, and then we have a mixed proliferation over here of both the parietal and the visceral epithelial cells. عندنا foci of fibrinoid necrosis. This is on trichrome. Over here بعد هني there is a little bit of fibrinoid necrosis over here. So we have both a rupture of the Bowman's capsule. ما قاعدين, there is no continuation of the Bowman's capsule. خلاص يعني it's kind of like ruptured. And then we have a proliferation of epithelial cells as well as a mix of inflammatory cells over here. And this is another glomerulus. ما عندنا rupture of the Bowman's capsule. We can see it in continuation. However, we can see the proliferation of the epithelial cells over here, as well as areas of fibrinoid necrosis and the rupture of the glomerular basement membrane. This is another glomerulus. عندنا fibrinoid necrosis, عندنا rupture of the Bowman's capsule, and basically the whole glomerulus over here has been replaced by just this proliferation of epithelial cells. اوكي عشان تتذكرون ان احنا قلنا في collapsing FSGS it's called a pseudocrescent, and how we differentiate between it and a true crescent, and there is no break في the glomerular basement membrane في collapsing FSGS is basically يعني maintained. But over here there is, you can see ان احنا اصلا ما عندنا يعني you don't know where is the line, وين الجلوميرولس, وين الجلوmerular tuft. All what we're saying is just this proliferation of epithelial cells. يعني had we had a little bit of tuft that's viable, you'll actually see kind of like break على silver stains. This is Jones silver stain, and you can see in basically it's discontinuous between the epithelial cells. There is rupture. حتى Bowman's capsule is rupture. يعني we don't have preservation لا of the glomerulus ولا of the glomerular basement membrane ولا of the Bowman's capsule. Everything is ruptured. Everything is inflamed. فدس Bowman's capsule هو اللي يساعد sorry السيلفر ستين هو اللي بيساعدنا على أساس إن إحنا we differentiate whether we are dealing with a true crescent or a pseudo crescent. Say collapsing FSGS, for instance. So this is بالنسبة حق الجلوميرولاي that are involved by the disease. الحين الجلوميرولاي اللي non-crescentic اللي ما فيهم crescents وش يبين عليهم؟ Unless they have another disease, unless مثلا هذا المريض عنده diabetes أو hypertension أو whatever أو عنده membranous, ساعات ممكن يعني dual pathology can exist in the human body. But say for instance يعني most of the patients ما بيكون عندهم dual pathology, and most of the patients will basically have only one pathology. فالمفروض إن في الجلوميرولاي اللي ما فيهم crescents they will look absolutely normal. ما بيكون عندهم لا thickening of the glomerular basement membrane ولا بيكون عندهم hypercellularity لا في الendocapillary ولا الميزانجيال ولا بيكون عندهم spikes ولا بيكون عندهم يعني basically they will look absolutely normal. They will have no pathology. So we have glomeruli that are crescentic, proliferative, and then we have glomeruli that look absolutely normal. Now on immunofluorescence, بيكون عندنا, as you know from medical school days, بيكون عندنا a linear bright intense, يعني intensity of 4 staining على ال IgG, and it's linear. يعني كأن أحد ماخذ, it looks like a ribbon, كأن أحد ماخذ خط وراس منها. Say for instance, في the crescentic glomeruli, you might actually find يعني rupture أو discontinuation في the glomerular basement membrane because of the crescent formation. But في the glomeruli that are non-involved by crescents, أو حتى the glomeruli involved by crescents, where we have viable GBM or tufts, we will have linear staining along the IgG. Another thing, إن إحنا بيكون عندنا بعد staining kind of like granular on C3. Another part that will be staining على IgG is the distal tubules. يعني مو proximal tubules. Some of the tubules will have linear staining على IgG. So all of this together will help you in kind of like making the diagnosis of anti-GBM. All right. This is how it looks على EM. Basically, ما عندنا deposits. We don't have electron dense deposits over here. What we will have is kind of like ischemic, wrinkled, sclerotic glomerular basement membrane, لأن مسكينة يعني ruptured وما عندها blood supply يعني basically diseased يعني. And we will have, look at this. This is the proliferation of epithelial cells. These are the parietal epithelial cells, مال Bowman's capsule, and you can see them. We usually never see them very evidently في الجلوميريولاي. احنا نشوفهم لما يكون عندنا crescent, نشوفهم كذي يعني رايحين داشين. This is the Bowman's capsule over here. This is actually a 3K, a very low magnification على electron microscope, so that we have kind of like a bird's eye view. This is the Bowman's capsule. This is the whole glomerulus over here, or about 2/3 of it. This is one of the tufts, had another tuft over here. We can see that what we have is basically shriveling and ischemia and wrinkling and sclerosis, and this is all proliferation of the parietal epithelial cells, مال Bowman's capsule. And like we said, we don't have any deposits. ما عندنا يعني, it looks absolutely fine, بس in a crescent formation. This is another picture at a higher magnification. We are here at 8K, and this is just to kind of like highlight to you, and now what we have is just a sclerosis. ما عندنا, we don't have any immune deposits, and all right, so we have the podocytes a little bit activated over here. يعني تشوفون شوية يعني في activation. بس طبعا whenever we have injury في glomerular basement membrane بيكون عندنا injury في podocytes. All right. So diagnosis, as you guys expected, this is an anti-GBM, antibody-mediated glomerulonephritis, and this is a medical emergency because it clinically presents as a rapidly progressive glomerulonephritis. Almost most of the time, the clinicians, they are expecting الdiagnosis. يعني إذا كان مثلا serology مالهم يعني جاهز وطلع لهم في السيرم there is NTGBM positivity, they are expecting. So what they are waiting for you to tell them is the percentage of crescents, how many crescents, is it more than 50, is it more than 90? What they are expecting of you to tell them is also the age of the crescents. Are they cellular? Are they fibrocellular? Are they fibrous crescent? لأن this will make a difference in terms of how aggressive they will be with the treatment. لأن هذا البيشنت basically will need a plasma exchange. فإذا هذا البيشنت مثلا معظم الكريسنت عنده fibrous، هذه الكدني خلاص باي باي راحت مع السلامة. بس إذا most of the crescents they are actually cellular، معناته إن this is possibly a reversible disease and they will be more aggressive ويا treatment of these patients. So patients they might either have an isolated renal disease or ممكن يكون عندهم a mild and inconspicuous or absent pulmonary symptoms. إذا كان عندنا both rapid progressive glomerulonephritis ويا pulmonary hemorrhage، هذا طبعا as you guys know اسمه Goodpasture syndrome. شنو الباثوفيزيولوجي of NTGBM؟ إن الانتيبوديز it's an autoimmune disease. الانتيبوديز they are against non-collagenous domain of type 4 collagen of the glomerular basement membrane. If you go back to the lecture in which we were talking about the structure of the glomerulus, and we were talking about diseases of the glomerular basement membrane, you guys know that احنا عندنا type 4 collagen في glomerular basement membrane. عندنا a part a non-collagenous domain في type 4 collagen في glomerular basement membrane is usually hidden، يعني ما يبين. إذا تعرضت هذه الجلوميرولس حق injury, infection or something يعني صار فيها injury، أوكي؟ وهذا الانجري يؤدي إلى أنه يصير عندنا يعني نوع الchange and it exposes the antigens. It's kind of like a just momentary change. فجأة هذين these domains will be recognized as foreign by the immune system. الimmune system مو متعود يشوفهم، فجأة يشوفهم it will think of them as foreign. فبيصير عندنا formation of يعني antibodies و antigen antibody complexes و it will attack it. فمن هالشي بيصير عندنا يعني all this basically autoimmune reaction against the glomerular basement membrane. ممكن it can be known as an autoimmune confirmopathy, and to be honest أنا ما عمري سمعت هذا الاسم إلا يوم أنا كنت قاعدة just reading around the topic to يعني present the topic for you, but I've never heard of it يعني I've never heard of this autoimmune confirmopathy. But anyways it goes ويا الpathophysiology of the disease. One last thing قبل نروح حق case 2 إن there is an atypical NTGBM اللي هو شنو؟ اللي هو ممكن إن السيرولوجي يكون negative بس الIF يكون positive. Do we still make the diagnosis? Yes, we still make the diagnosis. We call it atypical NTGBM. في هذه الحال clinicians بيقولون إليكم إن إحنا شاكين إن this is an NTGBM ولكن serology is negative، فبتكون an atypical NTGBM based on light microscopy and based on IF. Now, how do we differentiate between it and ANCA? And I checked the chat box, somebody was suggesting ANCA. As you guys remember, في الأنكا يعني we will have البي أنكا والسي أنكا بيكونوا موجودين في السيرولوجي بيكون يعني عندنا those. And on IF it's يعني posi immune. احنا ما بيكون عندنا يا بيكون عندنا less than intensity of 2 in some of the complements and يعني إذا كان موجود بيكون granular. بس في الانتي GBM we will have linear intense staining along the IgG. هذا الشيء ما بيكون موجود في الANCA disease. All right, so we'll go on now for case 2. Any questions? Is that clear? تمام. Okay, perfect. All right, case number 2 واجد حلوة خفيفة, as you guys are used to by now with me. يكون عندنا mix of difficult and easy cases. This case is of a 19-year-old man. He presents with nephrotic syndrome. common, يعني عنده proteinuria, عنده more than 3 grams, and he has a serum creatinine of 0.9, which is basically normal. يعني الrenal function مالته normal, عنده nephrotic syndrome, and they want to know why. طبعا in this instance the differential diagnosis مالنا يكون, are we dealing with minimal change? Are we dealing with membranous? Are we dealing with FSGS? Okay, واحد من هذين الثلاثة. Okay. Right. So this is the light microscopy, and يعني ما عندنا واجد acute tubular injury. عندنا شوية يعني fominess within the epithelial cells, and basically هذا يعني it goes with the proteinuria. There is kind of like protein resorption في ال tubular epithelial cells. And let me see, I was trying to show you something. Yeah, overall the glomeruli are all right. يعني ما عندنا يعني ما أدري يمكن شوية mesangial expansion هي بس مو واجد, not يعني not very bad, بس overall it looks all right. all right. بعدين نجي هني, إنزين هذه الجلوميريولس اللي شكلها طبيعي وحلو وكل شيء. What looked like it was mesangial expansion when we go on higher power, it's actually kind of like an obliteration of glomerular tufts. This is actually sclerosis. This is a sclerosed glomerular tuft. And then عندنا هني شوية foamy cells. This is a foamy macrophage. وملصقة it has made the glomerular tuft هني لاصق في البومنز كابسول, صاير يعني ملصقتينها, بس أنا ملصقتينها foam cell. And this is at the urinary pole. يعني إذا إحنا كان هني عندنا طالع أكو هذا هني, this is our hilar pole. هني هذا ال blood vessels هني, الافferent والefferent. Okay. Opposite to it, urinary pole مني صاير هذه الفوم cell ملصقة الجلوميرولار tuft, and we have segmental glomerular sclerosis. All right. شوف انتونا وش قاعدين تقولون. Yes, yes, exactly. Excellent. Very well done. So again, this is another glomerulus, and we have these foamy macrophages sticking the glomerular tuft at the urinary pole في البومنز capsule, and sometimes it looks as if it is herniating, يعني كأنه مثل الهرنية, كأنه هي herniating into the urinary pole. يعني مثلا هذه إذا إحنا أخذنا عليها further sections, further levels, بتبين إليها كأنه هي داخلة داخل فيها. It's herniating into it, it's protruding into it. All right. And this is the EM, and what we have in the EM, شوف podocytes, diffuse and extensive effacement of the podocytes. It almost looks as if it is minimal change. Okay, FSGS it is a podocytopathy. لكن في minimal change طبعا on light microscopy it looks absolutely normal. في FSGS بيكون عندنا segmental sclerosis. بس في FSGS يعتمد whether it is primary or secondary. بيكون عندنا ساعات segmental effacement of the podocytes. ولكن في minimal change بيكون عندنا extensive and diffuse and global effacement of the podocytes. The tip variant of FSGS, as you guys correctly have diagnosed this case, بيكون عندنا effacement مالتها almost like minimal change. بتكون kind of like extensive and diffuse and basically global, involving the whole glomerulus. Again, you can appreciate over here هذا effacement. ما عندنا ولا podocyte واحدة يمكن هذه بس ضايعة في النص. بس most of the podocytes are just, they're so injured, they're holding hands. There is complete effacement of the podocytes. Again, here you can see it. واحدة individual podocyte. They've all become one. كلهم صاروا واحدة. زين، لكن طلعوا ال thickness of the glomerular basement membrane absolutely normal. شوفوا endothelial cells flat. mesangial cells, mesangial matrix not expanded. mesangial cells في موقعها الطبيعي. So in reality, this is just a disease that is affecting podocytes. So, as you guys correctly said, this is focal segmental glomerular sclerosis. This is a tip variant, and it is characterized by the involvement زي ما قلنا of the glomerular capillaries at the outer tip for the urinary pole. الحين متى احنا نسمي ممكن ساعات إنه sometimes we can have tip variant alongside the other variants اللي هو الكلاسيك variant أو collapsing variant أو يكونون they coexist together. متى إحنا نسمي إن this is FSGS tip variant? When it is the only variant available. إحنا ما نشوف variants ثانيين. كل ال FSGS اللي إحنا نشوفه is of the tip variant. And why is that? لأن this has a very good prognosis generally. هو clinically the disease has a very good prognosis. So it has to be pure for us to call it a tip variant of FSGS. All right. And we talked about all of this, and clinically it behaves like minimal change disease with excellent prognosis. Okay, قبل لا نروح الكيس اللي بعدها. Yeah. Okay. All right. Am I talking very quickly اليوم؟ بسرعة وصلنا case 3. I don't know. شكلي قاعدة أتكلم وايد بسرعة اليوم. Okay. Case 3. This is a 53-year-old lady. She presented with a sudden decline in kidney function. بعد واحدة مسكينة ما فيها شيء، فجأة صار عندها sudden decline في الكدني function. وسووا إليها هاي الإكزامينيشن مالها وشافوا إن هي عندها lymphadenopathy. وشيكوا السيرولوجيز مالتها، سووا لها NT-GBM، سووا لها أنكا، سووا لها وشافوا إن هي عندها elevated serum IgG4. Okay, I know that you probably know what the diagnosis is, but let's talk about features. Okay, so in this instance, you will see a tubulointerstitial disease. Okay, بتشوفون tubulointerstitial inflammation in the interstitial compartment, and predominantly it is composed of plasma cells. alright بيكون plasma lymphocytic and predominantly plasma cells وبيكون there's lots of fibrosis in between or it will have kind of like a storyform pattern with kind of like the cartwheel يعني بيكون some of them are just kind of like radiating زي storyform pattern زي cartwheel and you will be thinking serum IgG4 is increased. Let's do IgG4 ratio, or let's sustain for IgG4. All right. So this is a closer look, and we have lots of plasma cells here. And lots of lymphocytes, fibrosis, زي ما قلنا, and the storyform pattern, that's kind of like radiating زي cartwheel. And on IgG, we will see إن إحنا عندنا granular staining along TBM, the tubular basement membrane. Okay, this is not to be mistaken with, say for instance, IgG. لأن شوفوا الجلوميرولار tuft نفسها is negative. وزي ما قلنا it's granular يعني granule صغنونة granular. It looks like if it is pseudo-linear. Okay, but it is along the tubular basement membrane. ما عندنا anything في the glomerular basement membrane. It's only the tubular basement membrane. Basically, هذين plasma cells, they are kind of like attacking the tubules and basically IgG4 is coming up. في IgG subclasses and I talked about it very briefly في اللكتشرات الأولية, the first two lectures اللي بتشوفونهم on the YouTube channel. بس يعني they're not always available and ليهم الuses مالتهم subclasses يعني we use them حق يعني to kind of like sometimes know whether the membranous is recurrent في transplant versus it being يعني de novo, and it helps us in kind of like monoclonal proliferative IgG disease and all of this, and يعني بيكون only one class, mostly I think IgG3 more than others. ممكن إن إحنا نسوي subclasses. إذا إحنا سوينا subclasses حق ال IgG in this instance, يعني IgG1, IgG2, IgG3, IgG4, بيكون عندنا positivity حق IgG4 as well as IgG1 and IgG3. Okay, but more like IgG4. But this is kind of like very specialized, and it's only in highly specialized centers بيكون عندهم ال subclasses مالت ال IgG. يعني for your everyday use, يعني just know إن you will have granular staining along the tubular basement membrane على ال IgG. All right. All right. So, the disease هذا, as you guys, I think you probably thought of it. Okay. Yeah, IgG4 interstitial nephritis. Okay, brilliant. Cool. All right, so as you guys have predicted, this is an IgG4 related tubular interstitial nephritis, and the diseases that are IgG4 related tubular interstitial nephritis, light microscopy as شيء بيكون عندنا lymphoplazmacytic infiltrate. في أحيانا قليلة ممكن يكون عندنا kind of like membranous disease ويا IgG4 disease. بس طبعا يكون PLA2R negative لأن it's a secondary صح membranous. ساعات ممكن يكون عندنا حتى يعني association with IgA nephropathy, but this is extremely rare. بس يعني just keep in your mind إنه يعني بيكون عندكم tubular interstitial nephritis. This is a classical case, and this is what I have seen. It's not very يعني described in the literature, but actually it can happen إن إحنا يكون عندنا IgG4 associated vasculitis. ممكن يكون عندنا vasculitis في in our biopsy because of IgG4. الشيء الثاني اللي ممكن يكون موجود is obliterative phlebitis في الفين. Okay, so we could have that. When we stain for IgG4 لازم يكون عندنا more than 10 IgG4 positive plasma cell per high power field. يعني نروح الهاي باور فيلد مالنا على times 40 ونشوف ان احنا عندنا more than 10 IgG4 positive plasma cells. او اذا احنا كنا نسوي الريشيو، إذا إحنا سوينا الستينز على الآي اس سي حق both IgG4 and IgG يكون more than 40% ratio، يكون more IgG4 than IgG positive plasma cells in the most affected areas. And ساعات يكون على الإلكترون microscopy we might have kind of like immune type tubular basement membrane deposits which are consistent with IF finding, but يعني they're not always easily discerned. طبعا زي ما قلنا if it was we associated يعني membranous أو إذا كان IgA we will have those، يعني بيكون عندنا ال EM features of those disease, but like I said very very rare. يعني it's more like a tubular interstitial nephritis rather than any other disease. بقى عندنا تقريبا 23 دقيقة and we are on our final case. Okay, هذه واجد حلوة. You guys gonna like this one. This is a 30-year-old prisoner. زين. He got admitted for an 8-day history of diffuse muscular pain. Prisoner يمكن راح على سترايك، يمكن حر السل مالته، اوكي، يمكن ما يشرب ماي، اوكي، وصار عنده body itching and cramming وflu-like symptoms، وصار عنده oliguria، صار عنده decrease في الurine output وblack urine. And then they found out إنه كان عنده acute renal failure and elevated liver enzymes. Okay. سووا إليه biopsy. glomeruli مالاته absolutely normal, nothing wrong وياهم. لكن شافوا إنه كان عنده acute tubular injury. There was a flattening, there was loss of the brush border حق epithelial cells and there was a flattening of the epithelial cells. وبعدين كان عندنا casts لهم ديلين. These casts. Right, okay. Okay, فكان عندنا هادلين الcasts and let's see how these casts look على different stains. هذه الأكيها الجلوميرولس حلاوتها ما فيها شيء absolutely fine. And like I said, like I always told you guys, best إن إحنا we يعني judge the thickness of the glomerular basement membrane, الميزانجم, all of that على special stains. لأن على ال H&E الميزانجم can appear as if it is thickened أو ممكن يكون عندنا apparent mesangial hypercellularity. So always kind of like judge on glomeruli على special stains. We have these kind of like reddish eosinophilic casts that are يعني causing this erosion في tubular epithelium and acute tubular injury. And yeah, these are reddish casts that are there. Again, this is kind of like close up of these casts, and they're not fractured. And I'm stressing on the fact that they are not fractured. Okay, they're highly eosinophilic. And this is trichrome, and they are red. They are brick red. And then extremely reddish in color. Okay, ساعات يكونون brown red, ساعات يكونون brick red, maroonish. Okay, close up, just to kind of like appreciate how deep red they are. And like you guys expected, these are myoglobin casts, and we can confirm this by doing immunohistochemistry, and it will stain the casts. Okay, هذا basically immunohistochemistry حق myoglobin, and it is staining the casts. نشوف وش قلتون. Yeah, okay, very good. All right, so this is a case of myoglobinuric acute renal failure, and yeah, it occurs in the setting of rhabdomyolysis, trauma. Somebody's gone through a crash, or somebody's fell, أو إنه كان seizure, they seized, and صار عندهم kind of like muscle loss, أو comatose state, أو hypokalemia, أو use of heroin, cocaine, or sometimes even statins. All of these can give us myoglobinuric acute renal failure. The cause, they are typically globular, and they appear hypereosinophilic to brown on HNE, and in PAS they are weak or negative, and like you have seen, they are bright red with trichrome stain. And they are positive حق myoglobin stain on ISC. زين أنا عندي مفاجأة صغنونة حقكم. We are going to compare these casts حق myeloma casts. Okay? Completely different disease, all right? But and I just want you to see what a myeloma cast looks like. طبعا الميلوما cast is completely different. يعني المyoglobin, this is just a breakdown of the muscle, صح, rhabdomyolysis. الميلوما cast, this is part of the dysproteinemias diseases. And in this instance, the patient بيحتاج إنه يسوون إليه bone marrow biopsy or bone marrow trophine. And but sometimes يعني the first time this diagnosis is made is actually on a renal biopsy. فالكاست هني بيكونون hard. You will see pictures. They are hard. They are fractured. زين. And they do stain strongly eosinophilic on HNE, and they are negative with PAS stain زي ربعنا ديلاك. But they are polychromatic via trichrome stain. لأن هم they are mixture. طبعا هم dominant of light chains, بس هم they are يعني mixture of the light chains with predominance of one light chain, and يكون عندهم شوية بروتين، ويكون عندهم شوية reaction من inflammatory cells، يكونون polychromatic. يعني ما يكون المايجلوبين كاست يكونون على الترايكروم يكونون برايت ريد. هذين يصير كأنهم يعني مو كريستالز، بس تعرفون يعني واجد ألوان مختلطة بعض، يعني شوية polychromatic, so many colors at the same time. يعني شوية هني أزرق، شوية هني reddish pink، شوية هني so many colors in one cast. Okay, and frequently يكون عندهم في الكاست نفسه يصير عندنا يعني inflammatory cell reaction، يكون عندنا giant cell reaction along with a mononuclear cell reaction. And on the immunofluorescence, if we are lucky and we have the casts, we will see in the tubular interstitial compartment بيكون يعني الكاس بيولعون on one of the light chains. مثلا بيولعون على كابا النوت لامدا، أو بيكونوا بيولعون على لامدا النوت كابا. So will be restriction of the light chain and يعني will be significant. يعني واحدة intensity of 1 والثانية intensity of 3، أو واحدة completely dark it is 0 والثاني 4 هاللون يعني. Alright, so this is the PAS. And how do we know that this is PAS? And a tubular basement membrane, it's like kind of highlighted. And it's kind of pinkish. And الكاست نفسه هو it is completely negative على PAS. يعني هني هذا our internal control هي كوها positive and this one is completely negative. Okay? And عندنا شوية inflammatory cells and يكون عندنا فيها fracture يعني كانها زي I don't know كراميل مكسرة أو قطع زجاج مكسرة. Okay. This is a closer look, and this is silver. Always we can tell through looking at the tubular basement membrane. واحد يقول أنا ما أقدر أعرف what stain we're looking at. Of course you can. Just look at your surrounding. Look for the clues in the surrounding. This is Jones silver stain. And we can see we have a fracture in this cast over here. عندنا inflammatory reaction around the cast. And this is lambda. This picture actually أنا أخذتها from AJKD. This is not my picture. All the other pictures are my pictures of cases that I have seen, but this is from the AJKD. And you can see on kappa it was completely negative. This is the tubule هني. This is a tubule أكو هني. You can see the outline my tubule over here. You can even see a silhouette of the epithelial cells. You can see إن هادلين الكاستس مولعين. يعني they are so intensely bright. And yeah, this is basically what a myeloma cast looks like. انتهينا وايد قبل الوقت, 15 minutes earlier. I just want to thank you all for attending the series and شكرا لتفاعلكم, and thank you very much for your interest and your attendance. And I hope in طبعا renal pathology is like every other subject in pathology. It's علم غزير, يعني we just touched the surface. الهدف من هذه السيريز كانت إن إحنا ما نخاف من الرينال بايبسي, إن نتعلم الأبجدية, and we know how to approach it, and يعني we know how to next time we see a renal biopsy, we know how to interpret the basic things and immunofluorescence and put things together. ولما نشوف الEM ما نتخرع, ما نخاف. يعني we know what to look for basically. That was the whole goal of the series. Okay, let me see. Right, thank you so much guys. اللينك مال اليوتيوب موجود على شو اسمه الاناونسمنتس اللي توصلكم على الايميل من الادمن. بتشوفون تحت at the very bottom اللينك على اليوتيوب channel. It's basically iHistopathology اللي هي نفس اللينك مال قناة دكتور أحمد. And the other thing is there was a question here بالنسبة إلى is it just from the crack that we differentiate it? No, it's not just from the crack. It's all those together. It's the polychromatic. It's a reaction مال giant cells and the inflammatory cells. It's على الاميونوفلوريسنس. عندكم light chain restriction. It's the fact that it's not bright red on trichrome. You're ruling out other causes of يعني cast nephropathy. And if you don't have the cast على IF, you can suggest it and you can ask them إن هم يعني you can suggest it and then they will take it يعني from there. They will do there's a lot of blood tests and they can do on يعني يسوون free light chains, يسوون urine analysis حق light chains, and then they will assess if it's worth it إن هم يسوون bone marrow trophine. طبعا doing a bone marrow trophine is a very serious thing لأن it's extremely painful. It's يعني it's invasive صح? They will have to. حق ال RPGN how many crescents احنا نحتاج؟ يعني basically يعني usually when we have an RPGN that means that more than 50% of the glomeruli بيكون عندهم بيكونون يسوون crescent formation. And sometimes يعني sometimes in NTGBM you can find 90% crescent formation. Sometimes you can find 50% crescent formation, sometimes 20%, sometimes 30%. It depends on the severity of the disease and it stay يعني like how early or how late it is in the disease, the area that they sampled. But يعني generally diagnosing NTGBM is a يعني very serious diagnosis. It's يعني life-threatening. It's an emergency. لازم they have to treat the patient right away. دكتورة إيمان, I wish I could, but I don't think I'm good enough to be giving you محاضرات in this scan. لا, I'm not good enough. We're going to start lecture series في GU, starting with the bladder. And we'll take it from there. Anyways, في أسئلة ثانية or prostate maybe later. I think prostate لأن غطيتها دكتورة رنا. prostate later. بنبتدي بالبladder and we're gonna take it from there. Thank you all for your wonderful feedback and thank you for الحضور and أقول لكم good night and see you next week.